Hello and welcome to a special interview for The Wire supported by Glenlivet Books. With the Omicron wave raging through the country and cases increasing at around 250,000 a day, we ask today, can India take reassurance and perhaps even comfort from South Africa's experience of Omicron? That's the key issue I shall raise today with Professor of Vaccinology and the Dean of the Faculty of Health Sciences at Witwatersrand University in South Africa, Professor Shabir Madhi. Professor Madhi, the 7-day average of daily cases in South Africa has been steadily falling since the 20th of December. It was 19,400 on the 20th. It was just 7,659 on the 9th. Does this mean that the Omicron wave in your country is fast subsiding?
Good, and thank you for having me. And the short answer is very much so. We've had a very short wave this time round compared to what transpired in the past. This time round, the wave has been for around about 8 weeks, whereas in the past it's been almost double that period of time. And probably the two main reasons behind this, firstly, is that Omicron is much more transmissible, and a very large part of the population probably got infected over a shorter period of time. But also contributing to that is the likelihood of extensive underlying immunity at the population level. In a South African context, not necessarily because of vaccination, but largely because of a high force of past infection. And that underlying immunity very likely also brings about a shorter duration of shedding of live virus, and also possibly contributes to reducing transmissibility of the virus eventually at the individual level. So we've experienced a very different type of a wave compared with what we experienced during the course of the first 3 waves. And we're very much at the tail end of this current wave with Omicron.
Can I first begin by picking up on that point you made that this wave with Omicron is very different to earlier ones? If I've got my facts right, Omicron was first detected in South Africa around the 18th of November, which means that in 7 weeks, cases first shot up rapidly, then peaked, and then collapsed equally dramatically. How much shorter was this wave compared to Delta and to Beta? Were they double in length?
Yes, that's exactly it. The previous waves lasted for around about 12 to 16 weeks. This wave has lasted just under 8 weeks. So pretty much half the period of time the previous waves actually existed. But at the same time, the number of people that were infected during the course of this wave probably is the same, if not greater, than the number of people that were infected in any of the previous waves because of the much greater transmissibility of the virus. So a much shorter duration of time, but the number of infections that transpired probably is similar, if not greater, than earlier waves.
Now, studies brought out very recently in South Africa, I gather their clinical trials suggest that Omicron has a far higher rate of what's called asymptomatic carriage than any of the earlier variants. A, is that correct? And B, if it is correct, does this mean that a lot more people would have been infected but not detected because they'd have remained asymptomatic?
Absolutely, and it's not just about people being asymptomatic. I think when you mentioned that as an example, 4 or 5 weeks ago in South Africa, we're reporting 27,000 cases per day with a population of 60 million. When the UK reports 200,000 cases per day, you can't make any sort of meaningful head-to-head comparisons because the UK right now is doing 20 times more testing than South Africa is doing. So when we're reporting 20,000 cases per day relative to what is happening in the UK, there's actually probably closer to 400,000 cases taking place in South Africa. So I think it's really misleading when we just look at the number of cases that are reported. It completely underestimates the number of cases that are transpiring when you've got such limited testing that's being done. And in fact, even then, South Africa does more testing than any other African country and probably has a similar sort of a testing rate than India. So when India is reporting maybe 200,000 cases per day, be rest assured that figure is probably closer to 2 million people that are being infected per day rather than 200,000. So that's the one aspect. We just need to be guarded in terms of how we interpret reported cases and how we compare it to other countries. The more testing you're going to do, the more cases you're going to identify. But in addition to that, as you correctly pointed out, what you're simply not doing in most countries is you're not identifying the asymptomatic individuals, who probably make up 40 to 50% of all of the infections that are transpiring at the point in time. So you're missing those, and you're also under-ascertaining people that are symptomatic but who simply don't come forward to be tested in the first instance.
But it's very important you said that asymptomatic infections could be 40 to 50% of the total number, which means that a very large number of people are getting infected over a very short duration of time, which also means that presumably Omicron would leave behind a lot of natural immunity.
Yep. So this, when we looked at women that were coming into hospital to deliver babies, who are routinely also tested for the virus, they're not being admitted to the hospital for COVID-19. They're simply healthy women that are coming in to deliver babies. When we tested them during the peak of the Omicron wave, 1/3 of them actually were testing positive for the virus. And these were asymptomatic women. So it shows you the extent to which people were infected with the virus at the time of the peak of the wave. And that is going to transpire in all places, and pretty much is also one of the reasons why in the US and the UK, close on to 40% of all of the so-called hospitalized cases are incidental infections, in that those individuals are not being hospitalized for COVID-19, but because everyone is routinely screened for the virus, even if they're coming in for an elective procedure, they're testing positive. So extensive amount of infection has taken place, and that is going to build on the extensive amount of natural infection-induced immunity that has built up since the start of the pandemic. Before Omicron arrived in South Africa, before this wave, at that stage, at least about 70% of South Africans had already been infected with the virus during the course of the first 3 waves. And that has probably contributed to this decoupling of infections and severe disease that we've now witnessed with Omicron wave.
I want very much to talk about the impact of Omicron in terms of hospitalization in South Africa. But before I come to that, let me step back one stage and talk to you about the illness Omicron leads to. From your experience in South Africa, can you now confirm the belief that A, the illness is mild, and B, it tends to last between 3 and 5 days?
Yeah, so it's really difficult to make head-to-head comparisons with earlier variants because there's 2 important factors at play. Firstly, with the mutations that occurred in Omicron, it makes it much more adept to replicating in the upper airways rather than in the lung, in the lower airways. And that consequentially will result in a different sort of severity of illness. That Omicron will probably cause a smaller percentage of people that are infected to end up with severe disease. So it's going to result in a shorter duration of illness as well. But on the other hand, what we also need to understand is that, like I said, there are differences in extent to which there's immunity at the level of the population now compared to 1 year ago, including in a country such as India, because of a high force of natural infection in the past, as well as because of vaccines being introduced. And that underlying immunity, even if it might not be adequate to protect against infections and allow for reinfections and breakthrough infections, that underlying immunity will attenuate the clinical course of the illness. So the characteristics of the virus, coupled with underlying immunity that exists now, which differs compared to what existed when the Delta variant was, as an example, circulating, results in a different clinical spectrum of disease, with majority of people now being asymptomatic or having much milder illness than would have transpired in the past in an absence of underlying immunity.
So if I understand correctly, and I'm just saying this in simple English for the audience, where we are confirming that the illness that Omicron leads to is mild, that it tends to last for somewhere between 3 and 5 days. What we aren't absolutely sure of is whether the mildness is a result of something that's intrinsic to the virus, or whether it's also a result of earlier underlying immunity from previous infection, or also from immunity from vaccination. Maybe it's all 3 factors, but at the end of the day, what is confirmed is that the disease is mild and it lasts 3 to 5 days.
Absolutely. And it's a composite of those factors that has contributed to a different and a milder spectrum of illness.
Now, does this mildness and the relative short duration of the illness apply to all age groups, or is it really only limited to those under 30?
No, it's across all age groups because the type of immunity that's evolved, because through vaccines as well as because of natural infection, is across all age groups, and that immunity protects against severe disease particularly well. It doesn't protect too well against infections, but it protects against severe disease. So the type of change in spectrum of illness, in severity of illness, is across all age groups and not just in younger individuals or older individuals.
This again will be very reassuring because there is a very sizable population in numbers terms, not in percentage terms, who are over 60, who will be a little apprehensive that if they get Omicron, will they fall seriously ill? And the South African experience is that the mildness of the disease and the short duration of illness applies across all age groups. Let me at this point, sorry, I was interrupting, carry on.
Yeah, no, absolutely. And when we look at the South African data, this decoupling that I've been referring to of infections, hospitalization, and death, in fact, the decoupling is most stark in the older age group because they were the most susceptible to end up in hospital and die of COVID-19 in the past. And that decoupling is most evident in that older age group that had the highest risk of hospitalization and death in the past. They still got the highest risk of hospitalization and death, but the difference between Omicron compared with what transpired in the earlier waves is much more manifest in that older age group. But importantly, that older age group need to be vaccinated. And in South Africa, that's the age group that have got the highest coverage of vaccines, above 55%. And also that's compounded with also a high level of past infections.
Let's now come to the impact on hospitalization of the Omicron wave. You already explained to us that a very substantial number of people in hospital actually are incidental COVID patients. They did not come because they had COVID. They didn't even know they had it. They came for other purposes. As you said, 1/3 of women who are pregnant who came for childbirth reasons to hospital turned out to be COVID without knowing it. But let me ask you this. How does the overall COVID hospitalization during Omicron compare to hospitalization during Delta and Beta?
They're worlds apart, completely worlds apart. South Africa this time round decided not to go to a higher level of restrictions. We were at the lowest level of restrictions ever since the start of the pandemic. And simply stated, none of the healthcare facilities came under any sort of threat of being overwhelmed. Despite society being completely open, we even got rid of curfews, which were present since the start of the pandemic. In the middle of the Omicron wave, government actually even abandoned all curfews. So the experience with the Omicron wave in South Africa is worlds apart compared to what we had experienced with any of the first three waves when it comes to the impact that it had on your healthcare facilities.
Do you have any idea of the percentage of people who became seriously ill because of Omicron that were unvaccinated and the percentage that were vaccinated?
Yep. So we do have some data for hospitalization and particularly severe disease, people that end up in ICU and that people that end up dying. And based on the data that's available, closer to 80 to 85% of people that ended up in hospital or died of COVID-19 during the period of this particular wave, they were unvaccinated or they were inadequately vaccinated. They might only have received a single dose when they should have received 2 doses. But the majority of them were unvaccinated. So absolutely no question that even in places where there's a high force of past infection, people that are unvaccinated still contribute disproportionately to the number of hospitalizations and deaths that do transpire even during the course of the Omicron wave.
In a sense, this is an unnecessary question, but nonetheless, I will ask it because the audience in India will want to hear the answer specifically. Am I right in assuming that because the illness caused by Omicron is mild and the duration is just 3 to 5 days, the death rate under Omicron is substantially lower than it was under Beta and Delta?
Absolutely. And the short answer to that is that when we look at all of the deaths that have transpired in South Africa since the start of the pandemic, the number of deaths that have transpired during the course of this current Omicron wave, which is at its tail end, contributes to less than 5% of all of the deaths that have occurred since the start of the pandemic. In contrast, the number of deaths that transpired during the third wave, which was caused by the Delta variant, contributed to 50% of all of the deaths that have actually occurred. And the 2 earlier waves contribute to just around about 20% each. to all of the deaths that have occurred. So we've seen a complete decoupling of infections and death and in this particular way compared with what existed in the past.
Would there be any reason, Professor Madhi, why the experience of South Africa with Omicron would not replicate itself in India? In other words, is there any reason to believe that we will have a worse time?
Well, obviously, in absolute numbers, you're going to have more people end up in hospital, more people die, but that's because your population is 20 times larger than South Africa. So in terms of absolute numbers, yes, you're going to have greater number of people infected, greater number of people reported in hospitals and die. But as a per capita of the population, it would be extremely surprising if India does any worse. In fact, India probably would do better than South Africa at two levels. Firstly, the amount of natural infection that occurred in India, even after the second wave, is the same, if not greater, than the amount of natural infection that actually transpired in South Africa. In addition to which, in India, you've actually got a higher vaccine coverage than in South Africa. South Africa doesn't have a healthy population. The mortality rate from COVID-19 since the start of the pandemic in South Africa is in the region of about 470 per 100,000, which is amongst the top 10 in the world. So biologically, it would be very difficult to explain why India would have any different experience compared with South Africa. And if anything, I think the odds are stacked in your favor in that you'll probably have even a less severe outbreak than what actually occurred in South Africa because of your higher vaccine coverage coupled with a high force of past infection.
This is again very, very reassuring. Before I end, can we look down the road a little? There is a view endorsed most recently, I see, by Marco Cavalieri, the head of vaccines at the European Medicines Agency, that because Omicron is highly infectious, but the disease a lot milder, its spread could be pushing the world towards some sort of endemicity. Would you accept that?
Certainly so. And it might not be Omicron that becomes an endemic virus, but SARS-CoV-2 is going to the endemic variant, but SARS-CoV-2 is very much becoming endemic. And it also depends what sort of metric you use to determine where we are in this pandemic. And if it's all about infections, we're going to continue experiencing resurgences maybe for another 1 or 2 years. Those are almost predictable. We will have new variants that evolve over the next 1 to 2 years. But if your main goal is about severe disease and death, then we have very much reached a turning point in this pandemic, in settings such as South Africa, in India, and any other place where they've got high level of immunity, either through vaccines or natural infection. And we've reached a different stage of the pandemic. We're very much going towards an endemic type of situation. And we need to recalibrate as to where we are based on what exists now, which didn't exist in the past, which, as I mentioned, is extensive amount of immunity, either through natural infection or through vaccines, which might not work too well in preventing infection, but work extremely well in preventing severe disease and death, which is what matters most.
I want to pick up on that thought about recalibrating our strategy in the face of Omicron and the fact that it may cause more cases, but it is mild illness only that results in. Should the strategy stress hereafter be on tracking hospitalizations, ICUs, and ventilators, and perhaps heavily emphasizing the need to continue wearing masks, rather than the old strategy of testing, tracking, and tracing?
Well, tracking, tracing, and testing in our type of context, both in South Africa as well as India, I think we are somewhat naive to believe that it has had any impact on the pandemic and on a clinical course, because we only diagnose less than 10% of infections to start off with. So 90% of the infections that do occur, we simply don't even identify them in the first place. And if you're not identifying 90% of infections, your isolation practices, your quarantine practices, your contact tracing practices is nothing more than window dressing. So you need to be identifying the majority of infections, asymptomatic and symptomatic infections, for quarantine and contact tracing to be of any meaning in the first place. So it hasn't really achieved much. And it's been our emphasis on that is very much misplaced in low and middle income countries where we do limited amount of testing. So moving forward, and that is a stance which South African government adopted with this wave, is that it decided not to go to higher level of restrictions, despite facing an increase in number of cases, and consciously decided that the only reason it would go to higher level of restrictions was if healthcare facilities were coming under threat in being overwhelmed. And that worked extremely well in that we didn't do harm to our economy, we didn't do harm to the livelihoods of people by locking them down, but at the same time, we eventually didn't even need to go to higher level of restrictions because the healthcare facilities at no stage came under threat. So moving forward, there's very little value, quite frankly, to be using large amount of resources to be testing ad nauseum in a community as to find out whether where we are with this pandemic. It's all about severe disease and death. So yes, we need to focus almost exclusively, for all intents and purposes, on tracking what is happening in our hospitals and what is actually happening with the death rate. And we can use other indirect measures, such as measuring wastewater, to see if there is any sort of changes in virus transmission that's taking place in the community as an early measure as to whether healthcare facilities might actually start coming under threat.
I want to pick up on that point you made about South Africa deliberately and consciously deciding not to increase restrictions right through the Omicron wave. In India, in contrast, we have weekend lockdowns, we have daily night curfews, private companies are required to actually work from home almost completely. There are all sorts of other restrictions on gyms, restaurants, and spas. They're not open at all. Are these restrictions misplaced and mistaken, in your opinion?
Absolutely. They're not going to achieve anything, quite bluntly. The virus doesn't only decide to transmit at night or over the weekend. The virus transmits throughout. And if you're allowing people to engage socially on a day-to-day level from 8 to 4, you're naive in believing that you're going to make any sort of impact, and more so with the variants such as Omicron, which is so much more transmissible. And where you're not identifying the majority of infected people in the first instance, you're achieving pretty much nothing. The only thing that you're achieving is actually damaging the economy and affecting the livelihoods of people and impacting on society.
So requiring offices to shut down and work from home, shutting down restaurants, shutting down pubs is not necessary, it's not advisable.
Yeah, if you want to do it, you need to go to full Monty, and you need to do what China does, which is basically shut down the entire country. But China is aspiring to a zero game of COVID, which is unlikely to succeed as well. So India is not aspiring to a zero game of COVID. And these sort of restrictions simply don't have any value. At best, what it might do is that it will draw out the number of infections that take place. It will extend it by about 1 week. So rather than having a wave that takes place over 8 weeks, it might take place over 9 weeks. So there might be some delay in transmission. But at a macro level, it's simply not going to achieve anything when it comes to the number of people that will end up being infected, the number of people that will end up in hospital, or the number of people that will die of COVID-19 with this wave.
Well, I hope the authorities in India are listening to you, and in particular realize that South Africa, where it all began, did not and deliberately did not impose serious restrictions, and the wave ended quickly. The illness was very mild. Hospitalization was a lot less. The death rate was a fraction of what it was earlier. And most importantly, perhaps 50% of people who were infected were asymptomatic, and no one even found out about them. I hope all of that is heard in India, and in particular, your stress on the need to monitor hospitalization, which means ICU and ventilators as well, and not bother with track and trace, because if you are going to miss 90% of infections, there's no point in tracking and tracing. But two last questions before I let you go, Professor Madhi. We know that vaccines against Omicron work very effectively in terms of serious disease. But we also know that the antibody arm of immunity virtually collapses against Omicron. How confident are you that the cellular arm holds up well?
Extremely well, and that's the reason why vaccines still work extremely well against severe disease. So Omicron is antibody evasive, but the T-cell immunity, the cell-mediated immunity that's induced, not only by vaccines, but also by past infection, those T-cell responses are relatively unaffected despite the number of mutations that have transpired in Omicron. And it is really the T-cell immunity which best explains why we're seeing this sort of a disconnect that whilst vaccines and past infection don't protect against infections due to Omicron, people that are vaccinated and that have developed immunity through natural infection, they still remain highly protected against severe disease and death. So the T-cell immunity clearly very much seems to be the main driver in protection against severe disease and death. And as I mentioned, even with the beta variant, the T-cell responses were relatively uninfected. The AstraZeneca vaccine, as an example, didn't protect against mild infection due to the beta variant, but still had greater than 80% effectiveness against severe disease due to the beta variant. And with Omicron, it's actually even worse in that there's almost no protection of any of the vaccines against mild infection due to Omicron, especially if you only get 1 or 2 doses of the vaccine. But when it comes to severe disease, the vaccines are reducing the risk after 2 doses by 70 to 80%. And after a third dose, that probably will go up to 90% and above. So vaccines are doing what vaccines are, the main purpose of vaccines has always been, and that is to prevent severe disease and death. When vaccines prevent infection, that is a huge bonus, but it is a bonus. It is not the reason why we produce vaccines. Against no disease do we produce vaccines to prevent infections. The main focus of vaccines is to save lives, and that is what vaccines are doing, even with Omicron. They're saving lives.
My last question, Professor Madhi, from your experience in South Africa, should boosters be given widely? Or is India right in restricting them to healthcare workers, frontline workers, and only to people over 60 who have comorbidities? If they don't have comorbidities, regardless of their age, they won't get it. So is India right in restricting it, or should boosters, from your experience, be given widely?
Absolutely. I think that is a correct decision. The only place I might differ is that anyone above the age of 60 should probably receive a booster, irrespective of whether they got underlying medical conditions. But there's very little reason, unless you still naively believe that you're going to be able to eliminate this virus at some point in time. There's very little reason to be giving booster doses to other individuals under the age of 60 that are otherwise healthy, because it might provide some transient protection against Omicron this time around, but in a few months, you're going to have waning of antibody. You're going to have waning of immunity against infection, be it due to Omicron or some other variant that arises. So trying to boost your way out of this pandemic with this naive aspiration of eliminating the virus, it's simply a strategy that is doomed to fail. So the focus needs to be on severe disease and death. People above the age of 60, after they've received 2 doses of vaccine, they do have high level of protection against severe disease and death, but that can be enhanced by giving that booster dose. So certainly anyone above the age of 60, I think there's a good case to be made to provide them that booster dose. And healthcare workers are a different category, a different reason why you're providing booster doses, which is also justified.
Professor Madhi, I thank you for this interview, and in particular, thank you for the reassurance that the South African experience will give to the Indian audience. I'll just repeat that the disease was mild. It lasted 3-5 days. 50% of people were asymptomatic. Hospitalization was a lot less. Death was just a fraction. And as you said, the important thing now is not to stress, track and trace and test, but to concentrate on hospitalization levels. I hope people listen to you, because your experience could be enlightening for us. Thank you very much indeed. Take care and stay safe.
Thank you for having me.